Hello, my name is Dr. Jane Crowe and I'm a prostate cancer GP working at the Australian Prostate Centre. This presentation is to help GPs to know what to do with an abnormal PSA result. So there you are, you're the GP for John Smith and you're checking your results at your computer. A result comes across for John and it shows that his PSA is 3.7. What do you do next?
PSA of 3.7. John is 53 years. I will just check his file. Let's see. No previous PSAs, no lower urinary tract symptoms, and no family history of prostate cancer. I'm not really sure what to do next.
So when you're interpreting the PSA, look at the absolute PSA. It matters. For a man of average risk over the age of 50, a PSA over 3 is the threshold. For a man in a high risk category, in his 40s or any time after that, a PSA over 2 is the threshold. If the man has any symptoms of lower urinary tract symptoms, then you should really go down the diagnostic pathway to do a digital rectal examination, check the PSA, check his urine and his renal function, and also perhaps do an ultrasound of his kidneys, ureter and bladder. So the presence or absence of symptoms is significant when you're interpreting a PSA. When you're looking at a man's PSA, it's also important to look at his family history and to see if there's a history of prostate cancer, breast cancer, ovarian or pancreatic cancer. A positive family history and especially an early age of diagnosis of relatives increase a man's risk of prostate cancer, so genetics matter. There are some very helpful resources for GPs. The Optimal Cancer Care Pathways are national guides to the best cancer care for specific tumour types. The pathways describe the key stages in a patient's cancer journey, from diagnosis to survivorship or end-of-life care, and expected optimal care at each stage to ensure all people diagnosed with cancer get the best care regardless of where they live or have cancer treatment. These pathways provide an agreed, consistent, nationwide approach and are based on the most up-to-date information, including clinical guidelines, standards and research. There are 2 health professional versions. There's a detailed clinical pathway for cancer specialists, health professionals and health service administrators, and there's a quick reference guide for GPs to familiarise GPs and primary care providers with the care pathway. The iPaste resource card provides information and tools to help the GP about critical primary care points, including information regarding prevention and risk factors, information regarding screening or testing recommendations, and this also includes a PSA testing decision aid, which may assist when you have your conversation with asymptomatic men. There's also evidence-based risk assessment tools to help assess patients with symptoms associated with prostate cancer, and to identify possible high-risk patients. The information and GP resources presented here about what to do with an abnormal PSA result have been developed according to the Cancer Council Australia and PCFA guidelines, which are available in full or short-form summary online. We mentioned earlier that when assessing a man's PSA result, the man's risk needs to be taken into consideration. So what determines a man's risk? Well, a man is of average risk if he has no family history and he has no symptoms. A man is at high risk if he does have a family history of prostate cancer, if there's a family history of BRCA1 or 2 gene mutations or breast ovarian cancers, if he's of African descent, and if there's a family history of Lynch syndrome. So once you've determined a man's risk, you then look at the PSA threshold for that risk group. It's important to note that if the initial PSA is over 10, then urgent referral to the urologist is indicated. This table is designed to set out the PSA threshold relating to a man's risk. So an average risk for the man with no symptoms and no family history, you could consider starting at age 50 and continue to age 69 with a PSA every 2 years. PSA can continue to be tested with consultation with the man after the age of 69 if his life expectancy is over 7 years. For this average risk group, the PSA threshold is over 3. In the high-risk group, this really depends on the man's family history. So if the man has his father or one brother with prostate cancer, you might consider starting PSA testing from age 45, with 2 yearly PSAs up to the age of 69, continuing thereafter if his life expectancy is over 7 years. You may start at the age 40 if his father and 2 or more brothers have had prostate cancer. Once again, 2 yearly PSAs and continue up to the age of 69 and continue if his life expectancy is over 7 years. So for men in the high risk group, the PSA threshold is over 2. As I mentioned before, if the initial PSA is over 10, refer. So looking at a man of average risk with a PSA over 3, the guidelines recommend to repeat the PSA in 1 to 3 months' time and also request a free to total ratio. For a man who is in a high risk category, please refer to the guidelines.
Okay, PSA over 3. So I'll repeat PSA in 1 to 3 months and request a free to total ratio. I'll ask John to come back in.
So to repeat, if the PSA is above the threshold, repeat the test in 1 to 3 months' time and request a free to total ratio. You might also include an MSU microculture and a urea and creatinine to check for renal function. It's also a good idea to advise the patient to avoid intercourse, ejaculation, strenuous exercise and bike riding for 48 hours before having the test.
What are the guidelines again if there's a family history?
This slide reiterates the importance of family history when assessing prostate cancer risk and determining when to refer based on a man's PSA levels.
Hi John, thank you for coming back in. About your prostate test, the PSA, it was a little high. As I mentioned to you before ordering the test, it means that we need to repeat the PSA and do a free to total ratio, as well as a kidney function blood test and urine test. We'll then need to go over the result and work out the next step.
What do you mean by free to total ratio?
Well, PSA circulates in 2 forms in the blood: unattached or free PSA, or bound, which means attached to other proteins in the blood. The amount of free PSA compared to the total PSA can give further clues about the prostate. A PSA with a free to total ratio over 25% is less likely to be due to cancer than a lower ratio. John, here is the pathology slip for another PSA test. Also a test for kidney function and urine sample. I suggest you wait a month before you have it, so maybe have it sometime between September and the end of November. I want you to avoid strenuous exercise, cycling, ejaculation or intercourse for 48 hours before you have the test, just in case it causes a temporary rise in the PSA. I would like to see you after you have the test.
So John had a PSA repeated 2 months later, and you also requested the free to total ratio. This result showed his PSA is 3.8 with a free to total ratio below 25%.
PSA 3.8, free to total ratio 23%. What does that mean?
This slide is the summary flowchart of what to do if the PSA comes back above the threshold, which is 3 for a man of average risk or over 2 for a younger man. If the initial PSA is over 10, automatically refer to a urologist. But if the PSA is over 3, repeat the PSA with a free to total ratio between 1 to 3 months. If the PSA comes back over 5, refer. If the PSA is between 3 and 5.5 and the free to total ratio is below 25%, you refer. If the PSA comes back below 3 but with the ratio above 20%, it's suggested you repeat these levels at 6 months. If you are not sure or you need further information, please refer to the guidelines. So this slide is just a flowchart for the man of high risk, for a man in his 40s and onwards up to the age of 69, if his PSA comes back over 2. Once again, repeat the PSA and the free to total ratio between 1 to 3 months. And if the PSA comes back over 2 and the ratio is below 25%, that's a trigger to refer the patient.
John, the repeat test shows the PSA is still mildly elevated and the free to total ratio is below 25%. Guidelines suggest you should be referred to a urologist to sort out what's going on in the prostate. As I mentioned at other appointments, PSA test is not a specific cancer test, but it's an alert that something is going on in the prostate. It could be due to benign enlargement, inflammation, or infection, or it could be cancer. So that is the reason to go along and see a urologist.
But Doc, what will happen when I see the urologist?
The urologist will examine your prostate by a gloved finger into the rectum, called a digital rectal examination. The urologist will most likely also arrange an MRI to image the prostate. This can indicate the size of the prostate and see if there could be any cancer there. Once the urologist has the information from the examination and MRI, a biopsy might be needed, but the urologist will explain whether this is needed or not.
What is a biopsy again?
A biopsy is when the urologist places some needles into the prostate to get samples of the prostate. The needles may be passed via the rectum or the skin between the scrotum and anus. Your surgeon will explain this in more detail. A biopsy is usually done under a light anaesthetic. You might remember we discussed this before your PSA test. This sample will tell us if there is cancer or not.
I suppose I would have to have the prostate out if there is cancer.
Firstly, if you have an elevated PSA and cancer happens to be found, this does not automatically mean you have to have prostate treatment via surgery or radiation. So the answer to your question is maybe. It depends on how aggressive the cancer is and how much is seen on the biopsy.
So this slide is just a reminder to uncouple the PSA test from automatic prostate treatment. Not all prostate cancers detected by PSA need to be treated.
If the sample shows you have a small amount of low-grade cancer, then active surveillance might be an option. This means you are monitored closely by the urologist with repeat digital rectal examination, MRI and biopsy, and only have treatment to the prostate if any of these indicate the prostate cancer has become a high grade. If the biopsy shows there is a lot of cancer or it is a higher grade, then radical treatment to the prostate is usually suggested. The two treatment options are surgery and radiation. John, if you ever get to the stage that you need treatment for prostate cancer, I'm planting the seed now that it's advisable for you to speak to a surgeon and a radiation oncologist about the treatment options before you proceed. There is no need to rush into treatment if a cancer is found. We have talked about a lot of possibilities and options. What are your thoughts about what I'm saying?
I might have to have surgery.
That may happen. Do you remember the other treatment option we talked about?
Radiation?
Yes, that is correct. I also mentioned that active surveillance is an option too, depending on your test results and what the urologist has to say. There's no need to rush making a decision about treatment, and it would be a good idea to speak to a surgeon and radiation oncologist before you make any decisions about your treatment.
The optimal care pathways recommend that a man who is diagnosed with prostate cancer and requires radical treatment should be offered a surgical and a radiation oncologist opinion. The pathways also suggest that the man's case have access to a multidisciplinary meeting. So you can request this as his GP when you make the initial referral. It's important to tell your patient there is usually no need for him to rush into treatment, but to consider all the treatment options before he proceeds.
Here is some more information for you to take home to read about what you might expect from here. It would be a good idea to discuss this also with your partner.
This resource has been developed to assist patients and their carers to understand the care pathway and what to expect at each stage. It's available at www.cancerpathways.org.au and it is available in English and 7 other languages.
So John, do you have any other questions?
No thanks. I am a little worried, but I understand what you've told me.
It might be worthwhile for you to come back and see me after you've spoken with your urologist about what management you may need. That way, I can help address any concerns you might have.
So, in summary, if a patient is symptomatic, treat him via the management pathway. But for a man with no symptoms who has an abnormal PSA, first of all, look at his level of risk. For a man over 50 of average risk, the PSA threshold is 3. For a man in a high risk category in his 40s, the PSA threshold is 2. Refer to your urologist if the PSA and the free to total ratio are in the ranges we discussed earlier and are highlighted in the clinical guidelines. If prostate cancer treatment is recommended, refer the patient for a surgical opinion, a radiation oncology opinion, and also request the patient have access to a multidisciplinary meeting.